Hey, good evening, everybody. I wish we were all in person. We're going to go about 100 miles an hour today. We're going to paint a very broad brushstroke about changing the way we think about Class 2 composites. And it's something that I do every day. So let's go ahead and get started. I'd love to answer your questions. We'll hang around just a little bit. I can't stop because we have way too much content because I really want to go from A to Z with this new thought process for Class 2s. So go ahead, enter all your questions, and we'll hang around at the end and we'll answer them. So I'm at the foot of Mount Rainier here. It's a dormant volcano. Hope it stays that way. It's really the logo that we have for our learning center here in Tacoma. And I hope at some point you could come and visit us and do a certification class here. You also can, if you'll email me at drclark@bioclarmatrix.com, we'll send you a PDF of tonight's presentation because there's a lot of great content that people sometimes want to look at later. We've got articles and videos that we put online. And so, like I said, feel free to email me at drclark@bioclarmatrix.com. We'll put the slide up at the end. So this is the modern method that we're teaching for dental schools and privately for modern composite. Number one, we have to remove biofilm by disclosing and blasting because our composites are not going to go in the tooth anymore. They're going to go around the tooth. So the infinity edge, or the ability for composite to really seal a restoration, is going to be dependent on removing biofilm because phosphoric acid does not remove biofilm. And that's why a lot of margins turn brown. Number two, modern cavity preparations. If you like, we can send you this model that we have for dental schools about the modern cavity preparation with its compression based versus getting away from mechanical retention, getting away from traditional margins. The next thing is modern matrices. We need to be able to injection mold and watch the material fill the preparation, go around the tooth. So we're going to be talking about BioClear matrices for the Class 2 today, and a lot of these are new for some of you that may be using older BioClear. The next thing is injection molded heated composite. Heated composite is starting to get more and more popular. And so for the ability for composite to really flow in a modern way, whether we're doing black triangles or a Class 2, heated composite is fabulous. The last thing is the Rockstar polish. We've got to make this stuff just sparkle. So we'll go over these steps that we do, that we teach to, like I said, to schools and at the Learning Center. All right. So this is a retentive cavity preparation. How many times in your career have you seen this? You know, it's like white amalgam. They all look like this after a while. And so this is a case that was retreated by one of our faculty, Dr. Charlie Regalado, with what's called a calla lily preparation. It's the complete opposite of retentive cavity preparation. And then we injection mold this tooth monolithically with a single layer. And if you look at some finite element analysis, you'll understand, and from some of the research that's been done, when you bite on a tooth with a retentive cavity preparation, over time the tooth flexes, and this composite does not strengthen the tooth. Composite in a normal cavity preparation is going to lead to the same failures that we saw in amalgam. So this case was retreated by Dr. Regalado, and with the finite element analysis that we don't have time to show you, you can put a tooth into compression. You can splint a cracked tooth, even a symptomatic cracked tooth, without having to crown the tooth. And for a lot of patients, they would much rather not have a crown. Now, here's the thing. In my practice, I give a patient a choice when they walk in with the tooth on the left. Hey, I used to put crowns on this tooth. Most dentists would put a crown on this tooth, but we got to take away 76% of the tooth. You may need a root canal later. That's fine. I can do a crown. Or I can do BioClear. I can rejuvenate this tooth. So if I've got a tooth that's kind of broken down, it's not a filling anymore. We call it rejuvenation. And Charlie Regalado charges about $1,400 for a crown. He charges about $1,200 for this tooth on the right. So even in an insurance-based practice, you don't have to do this stuff for free. Now, I know it sounds crazy for some of you that are kind of like me that was on that sort of insurance treadmill and, you know, you deal with the insurance covers. Elective upgrade BioClear procedures, when you offer these to patients, you might be surprised, even insurance-dependent patients. So anyway, don't think that to be more conservative, you're going to lose money. There is a way to be rewarded for conservative dentistry. Okay, so here's a bunch of cases that I've treated. Here's a row of amalgams with 10-year postoperative with the calla lily preparation. You can see that the margins aren't really staining or deteriorating like the old days. Here's a black triangle case on the bottom that I treated on an orthodontist that flew to see me from New York City who hated her black triangles. Now, we're not talking about black triangles. That's the next webinar. But realistically, the BioClear method is the same, whether you're treating a molar or a black triangle, for the ability for the composite to ensconce the tooth. creates a lot of possibilities that I never thought were possible for the first 20 years of my practice. These are some of the dental schools that we're working with that have actually adopted these modern cavity preparations and injection molded composite. I'm going to show you, we're going to start with a clinical case, kind of a simple case. This patient came in and had distal caries on the premolar. So part of the process is we're going to disclose and blast on every tooth. We do that at the beginning of the procedure, and we'll blast again to remove. We're going to talk about selective caries removal in just a little bit. The pre-wedging does a lot of good things for us. It compresses the papilla, starts to deepen the sulcus so the matrix goes in deeper. It gives us better visualization. It loosens up the teeth for better contact. So pre-wedging is free money. Just do it. It's a normal wedge. It's a diamond wedge, but we just put it in before, prep the tooth, and it makes your life a lot easier. So this is the modern cavity preparation. It's completely different from sort of what I learned in school. You can learn more about it by watching some of the videos. We don't really have time to talk a lot about the prep. This is the radius bevel. Looks like a double serpentine. That allows the composite to go around the tooth, reduces the C factor. We're not relying on mechanical retention, and we are doing selective caries removal as part of modern dentistry. Not exactly what we learned in dental school, is it? So this is the matrix height indicator / go, no go probe. Now, in the interest of fair play, if you don't want to do any of this BioClear stuff, you can try all of this with just whatever you got laying around. You could use a perio probe. You can use metal matrices. I don't care. But there's a real advantage to anatomic clear mylar if we want to do some cool stuff with composite. So this is called the matrix height indicator go, no go probe. Remember this for the quiz, okay? Matrix height indicator go, no go probe. This will determine if it's in the green to yellow zone that we don't have to layer. So I use Filtech 1. It has 5 millimeters depth of cure if you use a clear matrix and if you do what's called 3-point light curing. And that's on the quiz also, okay? 5 millimeter depth of cure with Filtech 1 if we have a clear matrix and if we're doing 3-point curing, which I'll show you in the video. So I don't have to layer this case, which is great. Now, as far as measuring, I've got a 5 millimeter cavity preparation. So we're always going to add 1 or 2 millimeters because the matrix has to go way beyond the margin to get a good seal. We'll talk about that. So there's the matrix. I've got it thumb down. You want to hold these sectional matrices for 10 seconds to be able to have them seat deeply, because at the end of the day with injection molding, the ligament and the attachment is what seals the gingival margin. The wedge is not everything anymore. When you injection mold with pressure, that matrix has to go into the attachment, and we see a beautiful seal. And we don't even need to use a wedge when we're doing a black triangle procedure. This trick is the matrix has to go into the attachment, displace the hemidesmosomes, and then it becomes self-sealing. That matrix a minute ago was sitting up 2 millimeters high. So you got to go in and push as hard as you can for about 10 seconds. It's like packing cord, and then boom, the thing is in there. So this is a large wedge. This is the new twin ring universal separator. It's got a lot more power than what we had in the past. Now we're ready to injection mold. Now, one of the cool things about Mylar is if we're going to actually grow the preparation and make better contacts, we've got to be able to see the composite flow around the tooth. Now, we'll talk about you have to clean this, you got to blast it, but these infinity edge margins allow us to get an incredible seal, way better aesthetics. It reduces C factor. A lot of things are really possible, but one of the best things is we're able to grow the contact. By growing the tooth, we can grow the contact, and everybody loves big contacts. Point contacts are out, man. It's like 1960. It's got to go. So this is a technique called the spot weld push-pull technique, and we've created sort of a super spot weld here. We'll go over the video. Once that's locked into place and the dentin's been cured, then we can injection mold, which is always adhesive, and then flow, and then paste. We'll show you here in just a minute. And then we disc, magic mix, rockstar polish, and there's the final outcome. Now, it doesn't exactly look like the class 2s that I did for the first 30 years. These are fun to do, and they're actually faster. Now, you're going to be slower at first, but injection molding, especially we can get past the layering, the finishing is a lot faster. They can be, pretty rapid to do. But in the beginning, you got to be committed to slowing down and understanding the process. So what I want you to take a look at is on the tooth on the left, it has this goofy point contact and next to a long, narrow embrasure. Patients really don't like that. So if we're going to create a caries-resistant outcome, we've got to create much broader contacts. We'll talk about the technique that we use to do that with this push-pull instrument. And then we got to have the ability to do additive dentistry. So all these things come together for a very unique outcome. You know, it's really weird sitting here talking to people without getting any facial responses, but that's the nature of webinars. Okay, so modern cavity preparations. So on the left, you see a GV black cavity preparation that they teach at a lot of dental schools. They use it for amalgam or composite. It's interchangeable. It doesn't make a lot of sense, but you know, dental schools do the best they can. But most dental schools are still teaching very sort of traditional retentive sort of amalgam or slot prep restorations with sharp margins that really don't help composite to thrive. So the Clark Class 2 is what you see here on the right. And we'll show you at the end of the presentation the steps, and we have a step-by-step guide. Now, if we don't get through all the material, you have a PDF that you can look at later for the steps of the new cavity preparation and access to videos, because man, 1 hour isn't a whole lot of time, but we're going to give it our best shot. So here's the final views of the Clark Class 2, the Biclear Prep. We've got about a 2 millimeter, what's called radius bevel on the occlusal. That puts the tooth into compression. Now we no longer need retention. But I just saw a patient about 2 hours ago, had a slot prep that already fell out. Slot preps are what's called a tension joint. So if we can roll the bevel over and create 2 millimeters of what we call x-axis, so to put the tooth into compression, kind of like a gold onlay, then you don't have to cut mechanical retention, because mechanical retention leads to a lot of dentin removal, fracturing, and pulpal sensitivity. So that's the modern preparation. All right, so we're going to remove myofilm out to basically where the matrix goes. We have aggressive radius walls or radius bevel on the internal and the external. And then when you injection mold, you're going to see in the video, your composite's going to flow basically to the edge of the matrix. So what's the margin? It's the edge of the clear matrix. So the cable surface grows dramatically, but these restorations, we just don't see recurrent decay. There's really no margin. There's really no place to get recurrent decay. So that's pretty exciting. So let's take a look at the matrices that we're using today. And once again, you know, if you want to use a Tafelmeyer, if you want to use flat mylar, rock on, it's fine. We just want to share these techniques that I think will be really helpful no matter what kind of matrix that you're using. These are the evolved matrices. The black one on the bottom is for premolars. You already saw that. The blue is a very curvaceous. You just can't put this much curvature in a metal matrix. They just don't curve that much. These have outrageous emergence profile, like the black triangle matrices. And then we'll show you the orange matrix here in a minute. So there's the black, the blue, and the orange. We showed you the premolar case. These fit just about every premolar, and they come in 5, 6, 7, 8, and 10. And I was doing a webinar to a bunch of folks in Vietnam. I said, when do you use a 10? I said, on a perio tooth with deep decay. I mean, I'm amazed how often I'll use 8 or 9 or 10 millimeter matrices. It's just, we've never had anything this tall before, so we didn't think about it. So I'm really enjoying these taller matrices. I mean, I built these matrices for me. So if you like them, that's great. But I need these. I need these things. So these are the two molar matrices. The blue is a little daintier. It's got really aggressive emergence profile. The orange is for, you ever done a restoration between the first and second molar and there's no space because the roots are convergent? Then you kind of almost need a Tafelmeyer. So we build a very flat matrix for that area. We call it the Bermuda Triangle, where matrices go to die, basically. So we'll show you some cases on those if we have time. All right, here are the blues, 5 to 9. Once again, outrageous emergence profile. They have a gingival extension. So any matrix with a gingival extension, no matter who makes it, you have to drive those things apically because they have some resistance at the apron. So we'll even show you if we have time, where you actually pack cord on some of these to let the matrix seat deeply, because that gingival extension assures you a good seal, but sometimes it sits up high. So you got to drive these things apically. Here's the orange. These come in fewer sizes. We don't use them as often. Once again, when do I use these? Up here, where the roots are convergent, where you have no room, the roots are tight together. You usually lose a little skinny wedge. So this matrix is very wide and very kind of flat-ish for that unique situation. This is the matrix height indicator. Once again, it's in the quiz. If you're in the green or yellow zone, you don't need to layer with Filtech 1. If you're in the red zone, let's say your cavity prep is 7 millimeters deep, you'll need to put 2 layers in. One gingival increment, cure that. then injection mold the rest. So it's either what we call a 2-point or a 3-point spot weld. So there it is. It's a matrix height indicator. You always add 1 to 2 millimeters to whatever you're measuring here. So let's say the prep's 5 millimeters deep. The matrix is going to be at least a 6 or a 7 because the matrix is always going to be deeper than the edge of the prep. You don't want the matrix sitting at the bottom of the prep. That's not deep enough, man. It's got to go past the edge of the prep. All right. These are the diamond wedges that we're going to use in the case. This is an interesting wedge. I invented this as the sulfurcation, which is great when you have a fluting or deep decay or a fluting like on the mesial of a first premolar. It's always a problem to get an overhang there. So these are the diamond wedges. So we're going to talk about the twin ring universal that we used in the case. So if we're going to have a snug contact, there's 3 things that we're really going to need. Number 1, we're going to need power. No matter what kind of separator you're using, you need strategy and you need technique. So a strategy would be, say, for a quadrant. We'll talk about that at another opportunity. But if you want a nice, strong matrix, then you're going to want to have enough power to separate the teeth, to build up kinetic energy in the system so that when the matrix comes off, the teeth come back together. And the more powerful the separator you have, the tougher and the stronger and more emergence profile matrix you can have. So with Mylar, you want it a little bit thicker than that flimsy stuff we used in the past. So we need power if we're gonna use these beautiful anatomic clear matrices. So we'll talk about power now. So this is a study that Nate Lawson did comparing separators. So even if you want to just keep using your old separator, that's fine. You want to learn from this video about how to maximize your separator. So this is, I want you to watch up here in the upper left hand, and this is a Instron reading, and we're going to measure the separation pressure of some different separators. So we're going to come in here first with the twin ring universal, and watch up here with the Instron reading, and it's going to be at 21, and it goes to 28. So you have to wiggle your separator apically like a rubber dam clamp. I know that seems dumb. It's not dumb. You'll pick up more power. Here's a Garrison. It's coming in at about 17 newtons, then he wiggles it and it goes up to about 18. So you're going to see that all these separators have more power if you wiggle them apically, pick up that little extra. So there you go. So here's a little bar chart comparison. Now, in the test, all of these separators had been used for about 6 months that Nate used at University of Alabama. So a lot of these separators wear out over time. And by the way, you can't bend them back. They've undergone plastic deformation. So the way that I built the twin ring universal is these twin nickel titanium wires, they do not lose their power over time. So if you want to use a clear, strong matrix, you're going to want to be around, north of 25 newtons of separation. It's just, it just, it really doesn't make your day when you take the floss and it goes like that. That's the worst feeling. So, I mean, I struggled with that for 20 years, but we're really having great results with this technique along with this great instrument. And you can, like I said, you can make one of these instruments at home. If you don't want to get one of these, the technique will work with whatever you're using. All right. So the last thing we want to talk about is this thing called the slip-off test. So when you're working with the separator, it'd be nice if they didn't fall off the teeth. So we redesigned the twin ring universal. We'll take a look at this situation. Let's take a look at the new twin ring universal with its incredible ability to stay put on a tooth with poor undercuts or short teeth. This is a model that I took a few years ago when we were doing a class 2 on my nephew, and we could not get the separator to stay on the teeth. So this is a great model because it has very poorly erupted teeth, and yet the twin universal has the ability to stay in place. Let's compare that with a standard separator. This is the Garrison. We try to put it on this area. It's an exercise in frustration. Try it one more time. And when this slips off on a patient, it's incredibly stressful and even dangerous. So if you don't, like I said, hey, Dr. Clark, I want to use what I'm using. One thing you can do in a case like this, where a traditional separator falls off the tooth, you can actually acid etch little Invisalign buttons like mid-tooth, and then you can lock in one of these older separators that slips off the tooth. It's more work, but it's actually possible. And back when we had our older separators, I would actually do that. I would much rather have a separator that actually grabs the tooth, though. So that's a real advantage. So let's go back to 2007, and let's go back to actually where most dental schools are today. And they said, hey, Dr. Clark, aren't I supposed to layer everything? I just spent $500,000 going to dental school, and they told me I had to layer to mitigate polymerization, shrinkage, stress. Well, it's bad science. So this is the work of Dr. Richard Price. He's going to compare a dentist who layered a class 2. You can see 1, 2, 3, 4 layers. And it's a little like a little origami too. So this doctor goes in, he layers just like he was taught, and then he put it in a special die, and it shows these, they're called knit lines, K-N-I-T. It reduces the strength of resins by up to 70%. So we know that layered composites are always weaker, just like layered porcelain was weaker. Same doctor went in and injection molded 5 millimeter depth to cure. With this was Filtech 1 bulk fill. Boom. Look at the difference. Doctor number 2, look at the layers. 1, 2, 3, 4. Plus it takes all day. But the thing is, we were taught that we had to layer for mitigation of polymerization, shrinkage, stress. Well, in a minute, we're going to tell you that that doesn't work either. So layering is done. It's over. We don't want to do that in the posterior anymore. And I know that 5 years ago, people were, about this, but the science tells us that this is definitely the way to go. Now, we do have to pay attention to depth of cure, and it's really helpful to have a clear matrix to get to true depth of cure. It's tough to do that with metal. So is layering a good thing or a bad thing? Does layering relieve stress and reduce micro leakage? Absolutely not. So this is a study that was done. There's actually 8 studies that were done. All of these studies tell us that layering does not mitigate polymerization, shrinkage, stress. Let me repeat, 8 studies here that says layering does not fix the problem. If you cut a retentive cavity preparation, you're going to have polymerization shrinkage that's not helpful, and it's going to pull the margins open. So this is the study done back in 2011 in the Journal of the American Dental Association, saying that layering, no matter how you cut it, does not help. So you can layer it 6 different ways. Eventually, the polymerization shrinkage just pulls the composite off the walls. How do we fix this problem? Number 1, cut a modern cavity preparation that has low C factor, like this model that we're going to show you here. And the number 2 is a bulk fill helps a little. They're less bad. But without changing the cavity preparation design, C factor is still going to be a bit of an issue. But layering doesn't fix it. So are we done layering? Okay, we're done layering, except when they're really deep. Okay, so here's a layered tooth. We had a dental student do this. They put some flowable in, cured it. We had the flowable dyed green. And then here's the paste put in by hand with the metal matrix. You can see that you've got gaps. You've got a rough finish that metal gives. This is the same thing with clear BioClear matrix. It's infinity edge, monolithic. It's just a better, stronger, faster restoration. So here's a little study we did at University of Alberta. These are a bunch of dental students. We went up there and said, okay, let's compare. Let's let these kids do an injection molded class 2. So we took one of these dentiforms. We gave them a 10-minute explanation. And then we had 36 out of 37 teeth that were basically perfect. So they've done multiple studies at someone at Roseman Dental School saying the number of mistakes goes down. It's just so much simpler to do than try to condense and layer a composite. So 10-minute explanation. So the students did great. This is a study done by 3M showing the number of voids. For layering, you're going to expect voids about 60 or 70% of the time, even with sonic fill. With Filtech 1, when you hand pack it, you're still going to get voids 30% of the time. But what we saw at the University of Alberta study is, 2% of these have voids, and that's from somebody who just made a big old mistake. So injection molding monolithic composite is just better, faster, and stronger. So biofilm removal, we talked about this. If we're going to take the composite and go around the corners, we've got to remove biofilm. So people say, hey, David, doesn't phosphoric acid clean the tooth? Can I use a prophy cup? Well, I know people don't ever want to get anything new. I get that. But we will not work with dental schools with these modern cavity preparations unless they're committed to at least using disclosing solution on the outside of the tooth. So let's ask the question, hey, David, can I just use yada, yada? Can I just use phosphoric acid, or do I really have to worry about biofilm? So here's the video. So We're going to go ahead and disclose the tooth like we always do. And then as a study, we're going to acid etch this area where the infinity edge of the modern class 2 is going to go. So this is time-lapse video, 20 seconds, acid etching the infinity edge, and then ask yourself, did that phosphoric acid do anything in 20 seconds? Not really. It turned it from purple to green. Why? Because phosphoric acid selectively removes the mineral, not the organic. It can't remove the shag carpet that's on the tooth. It's not just biofilm, it's the protein pellicle. So we blast in the beginning to remove the biofilm, and then we'll blast one more time at the end, because if we have time, we'll talk about selective caries removal. And the best way to do selective caries removal is actually with a blaster, not a burr or a spoon. That's sort of old thinking. Now, some of you are telling yourself, is this guy from Mars tonight? Because I've never heard of any of this stuff. Now, a lot of you have already heard of some of this also, so I'll be really curious to see where people are with your Q&A. And one thing that I've been doing for 29 years is I use an operating microscope for all my dentistry, because I am the world's biggest nerd. And one thing I learned under the microscope, a lot of the stuff they taught us, guys that were barely using 2x loops, they couldn't see the problems. So 30 years under a microscope, it leads you to a lot of critical thinking and really criticizing your own stuff. And then you think, okay, let's rethink this. Let's do something better. All right, so this is a BioClear blaster. You can also use a Prophy jet with aluminum trihydroxide, and we always use it with water. And the sweet spot for blasting is aluminum trihydroxide. Now, a lot of people want to use air abrasion, which is 40 times harder. So if you're going to try and clean the tooth with air abrasion, it's kind of like giving a guy a haircut with the chainsaw. I mean, you can do it, but it's a little overkill. So we don't want the schools using aluminum oxide, because you have accidental pulp exposures. It takes the glaze off of porcelain. You accidentally cut the other teeth. So, I mean, aluminum oxide is for cutting holes in teeth. And if you're very skilled, you can certainly use aluminum oxide if you know what you're doing. But the aluminum trihydroxide is just way safer. So it's 40 times softer. And that's what we use in the BioClear blaster. And that's also what's in the Prophy jet. Now, glycine, too soft. Erythritol, way too soft. It'll take all day to get it done. I mean, you could use it, but it's just slow. So we can talk about this. People always have questions about the blasting, so we can certainly chat about that. All right, creating amazing contacts. Here we go. So this is the video that kind of wraps it all together. This video is also, along with other instructional videos, is available. If you'll email me, we'll give you a link to all these videos. So I'm going to let this video play, and then interrupt me if you can't hear the sound.
Welcome to the BioClear step-by-step guide for the injection molded Class 2. Finish the Class 2 preparation and remove the pre-wedge. Remove loose enamel rods and hard deposits like calculus with the Comet diamond strip. Blast both the inside and the outside of the tooth using the aluminum trihydroxide in the BioClear blaster. Optimize the neighboring contact with the disc. We like to use the 3M SoftLex XT coarse disc in the inverted position. Measure the cavity depth guide using the Evolve matrix height indicator and go, no-go probe. You can go ahead and measure inside of the cavity prep, and then go ahead and measure outside of the cavity preparation to assess where the gingival attachment is. The BioClear Evolve matrix is rugged and will withstand heavy seating pressure. Trap the tab of the matrix against the neighboring marginal ridge during insertion to keep the matrix fully seated and stable. Push as hard as you can for 5 seconds to fully seat the matrix. The tab should be centered as shown. Continue to push on the matrix while you insert the diamond wedge. Push the wedge as far as you can with the back of the cotton pliers once it's been inserted. Place the twin ring universal. The twin ring has 4 hands that will straddle the wedge. Once the twin ring is placed, gently rock the twin ring apically like a rubber dam clamp to assure full seating and full power. Place the phosphoric acid etchant. Make sure to inject acid etch all the way to the edge of the matrix, which is the infinity edge area. Then etch for 20 seconds, rinse and dry. Place and massage the 3M Scotch-Bond Universal Plus adhesive into the dentin tubule areas. You will do this for 20 seconds. Air thin the adhesive. Place 2 beads of room temperature 3M Filtech bulk fill flowable restorative, 2 millimeters in diameter, inside, over, and outside the corners of the matrix near the cusp tips. The push-pull instrument is placed inside of the cavity preparation with pressure mid-coronal apical to approximate the matrix for a broad, tight contact. The assistant will light cure for 1 second on each spot weld area while the doctor holds the push-pull instrument. Cure again after removing the push-pull instrument. Second application of adhesive. The cavity area and infinity edge areas are wetted using 3M Scotch-Bond Universal Plus adhesive as a surfactant, allowing good flow of composite. Air thin the adhesive, then inject heated flowable. Slowly inject the warm 3M Filtech bulk fill flowable restorative at 90 degrees to the matrix tooth interface, which will displace the uncured adhesive.
Watch it go around the corner. That is so cool. That is fun.
Inject heated Filtech 1 bulk fill paste composite. The heavier paste composite will displace most of the warm flowable composite, leaving a strong, seamless restoration. Quickly shape the composite. A central groove should be placed with the composite massage toward the cusp tips. Do not over-manipulate or marginate the composite. Light cure the composite for 10 seconds on the occlusal surface. This is the first step in 3-point curing. Remove the twin ring and then light cure from the buccal and the lingual. Make sure to cure from the buccal and the lingual for 10 seconds each. Remove the diamond wedge, then release the matrix from the tooth with an explorer. Spin the matrix out with the hemostat. Initial cutback. A football-shaped diamond burr or carbide is used to cut back gross excess and begin to create simple fossa near the contact area. Leave slight excess, marginating later. The Q-Finisher carbide is used to create simple anatomy and to begin to marginate the occlusal surface. Sculpt the restoration with the disc. A 3M Softlex XT coarse disc is used to round the marginal ridge. Keep the disc out of the deep interproximal areas in order to maintain the smooth mylar finish. Placing the disc in the inverted position is often very helpful for sculpting. Slide the safe area of the Softlex strip through the contact, then strip the gingival with coarse and fine grits. The Magic Mix pre-polish. BioClear Magic Mix is applied in a disposable cup for further margination and pre-polishing. Actively move the cup and the mix to all areas, replenishing Magic Mix to the cup every 3 seconds. Rockstar Polish. The BioClear RSP polisher is used with light pressure in the dry phase and then heavy pressure in the wet phase. Your assistant will blow a gentle airstream during the dry phase and constant full air water during the wet phase as the doctor applies heavy pressure to the cup. Final outcome. The BioClear Class 2 is a welcomed update of the traditional Class 2. It is both aesthetically and radiographically beautiful. It is smooth to the patient's tongue and comfortable in function.
So I've added some new stuff. We're going to take a look at a little bit of some of the finite element analysis that was done to validate the fact that when you go around the tooth, it's this infinity edge. The C factor is extremely low. And that's one of the reasons we have such a great seal and such a reduction in leakage, stain, and sensitivity. So the 2-point spot weld technique is what I just showed you. So you saw that I put 2 little dots of flowable, pushed the matrix over, cured it. That locks it in place, builds up some more kinetic energy because you really push on the matrix. It's pretty strong. And then we injection mold. So we're going to do these 2 welds when the cavity prep is 5 millimeters or less in the interproximal. Typically, there's enamel on the gingival margin. So we co-cured the adhesive on the dentin when we cured the little buttons of flowable on the enamel. So here's the deal. If you have exposed dentin, you have to cure the adhesive before you injection mold. Let me repeat. If you have exposed dentin, you have to massage for 20 seconds, air thin, and cure, just like the old days. But while you're at it, you do a couple spot welds, push the matrix over, and then you get a 2-for-1. We love having a 2-for-1, right? We're going to pre-cure the adhesive on the dentin and then cure those little spot welds up on the enamel because you don't have to pre-cure the adhesive up there. Now you're locked and loaded, ready to injection mold. This makes your life so much better, so predictable. You're not going to have to fight that matrix anymore. It is locked exactly where you need it. It's totally adapted, and we're done with burnishing. Burnishing's like smoking cigarettes. It's a nasty habit that I had. You got to give up the burnishing. So with clear mylar, you can't burnish it anyway. So this basically replaces burnishing. So this is an adjustable push-pull instrument. Once again, in fair play, if you don't want to get any of this stuff, that's great. You can make this stuff at home, right? Get a pair of cotton pliers and try it, right? But the technique is really helpful. This is a brand new instrument. I love this thing, man. I take it to dinner with me, right? This thing is so fun. So you'll be able to adjust for the width of the contact that you want because it's really pretty highly variable. So we'll play this little video. Once again, if you want to make one of these tools at home, feel free.
Congratulations on your purchase of the new adjustable push-pull instrument by BioClear. Let me explain how the instrument works. I'm going to set the slider button back to the smallest position at 4.5. This would be appropriate for the premolar or black evolved matrix. For most molars using the blue evolved matrix, use the setting at 5 to 6. For wide molars using the orange evolved matrix, use the setting at 7 to 8. For smaller cavity preparations, we will need to use the non-adjustable small end of the push-pull instrument. Then, for extremely small cavity preparations, we'll use the convex end of the BioClear paddle instrument. I'll show you several clinical indications on when to use these instruments. Let's start with the premolar. For premolars, we are going to be around the 4.5 number here. This corresponds roughly to the outside dimension between the outside of these two little hands. So when we're doing the spot weld push-pull technique, which you can see in a separate video, we put two little dots of cold flowable composite here and here. And then before we light cure the adhesive, we're going to go in, put the push-pull instrument in to parallel the neighboring tooth. So let's take a lateral view of this. The hands of the push-pull instrument should be parallel to the contact area of the neighboring tooth. So to accomplish this, we don't want the handle of the instrument to be too low or too high. It's a good idea to practice before you begin to do the restoration. Let's zoom in and watch how beautifully that we're able to adapt and approximate the matrix with the new adjustable push-pull instrument by BioClear. Let's go ahead and take a look at another case. Here we have the blue evolved matrix on a molar. For the blue evolved matrix, I'll be between 5 and 6, depending on what the neighboring tooth looks like. If there's a small premolar next door, you don't want to expand the contact too much. So in this case, I'll be at about 5.5, which is appropriate for this case next to a premolar. So I'm dropping the instrument in and pulling the matrix over. So that's using the pulling motion to approximate the matrix on the mesial. Now let's go ahead and look at a small cavity preparation. So even though I have the setting at about 4.5, it's barely fitting into the small cavity preparation. So this would work, but if it was any smaller, we would need to use the small end of the push-pull instrument or the non-adjustable end of the push-pull instrument.
Okay, so we're going to go ahead, and if you want to learn more about that instrument, it expands to a very large diameter for the orange or wider matrix, but there's some cool stuff I want to get to before the end of the presentation in 10 minutes. So I promised you a little bit of finite element analysis. This is Dr. Alex Falk. He's a phenomenal structural engineer that did a lot of research on these new cavity preparations. And so let's take a look at one of these cool studies. So this is a GV black cavity prep on the left. Wherever you see pink and yellow and green, that's tension for when the composite shrinks away from the walls. Look at all of the poor C factor resulting in a lot of stress during polymerization shrinkage and a slot preparation. A slot preparation has terrible C factor. And then here's the Clark class 2, where the composite goes around the tooth. You see all that blue? It's actually shrinking into compression. The C factor is so low at the infinity edge, it basically hugs the tooth. They don't leak. They don't stain. It's incredible. And most of that is happening on enamel with the Clark prep. So if you have any stress, it's on the enamel, not on the dentin. So this finite element analysis was great. This really helps the schools to move forward to get away from these retentive cavity preparations. So here's a contrast. There's all this ocean of blue on the infinity edge where the C factor is low, and a slot preparation has lots of polymerization, shrinkage, stress. So even if you put a bulk fill in here, it's not going to mitigate all the polymerization, shrinkage, stress. And like I told you, layering doesn't fix that. What fixes it? A new cavity prep. So I'm glad we had a minute to share some of this cool research. Like I said, we got a lot more of this when we have more time, but it's kind of nice to see this great work that Dr. Falk did at Minnesota. So this is what the normal class 2 looks like in America. That is the standard of care. It's not an adhesive problem. That's not going to fix it. This is an engineering problem. So here's retreated with the BioClear method with the infinity edge. And it's just fun to do. Now it's the opposite of what we used to do. I get that. But it is, like I said, a lot of doctors are having a lot of fun with it. And, a lot of schools have now adopted this. So it's great. So that's the infinity edge or tooth restoration interface. We got about 8 minutes to go. Let's get as far as we can. Now, we're not going to put deep grooves in teeth anymore. We're going to leave very shallow grooves because of this epidemic of fracturing teeth. And so we used to think that amalgam was causing the fractures, but in reality, the third leading cause of tooth loss, fracturing, is not going to be helped by composite. So here's a composite and a well-done cavity preparation. The enamel broke after 4 years. So putting composite in a retentive cavity preparation makes zero sense. So the modern preparation is infinity edge, compression-based, and enamel-driven. So infinity edge, compression-based, and enamel-driven. That creates a completely different outcome. So the next thing I want to talk about, we're kind of going to bounce back to contacts here. So what we want to have is an aggressive rounded emergence profile versus these sort of Toffelmeyer contacts with metal matrices and a tall wedge. These result in contacts that are not very stable and a lot of food impaction laterally. So when it comes to comfort and longevity, composites need to look like a bowling ball. These brittle materials need to have a very round shape. So not only is this shape not that great for patients, it also leads to fracturing. So we want to sort of mimic nature with this rounded emergence profile. So we have, point contacts, burnish contacts, open contacts, and overhangs. Like going to a restaurant where nothing's good on the menu, right? So there's a guy that walks in, and he's got this composite in here, and looks, the contact's tight, and it's been burnished. It's a typical burnished metal matrix, and the X-ray looks okay. But if you angle that X-ray just a little bit differently, what do you see? Burnishing. It's not the same. And so I spent 25 years doing this, and I'm never going to do that again. I mean, it gets the job done. It closes the contact. And I don't know about you. Maybe you can get perfect outcome with the burnishing and metal matrices, but I am done. So anyway, these are the 8 keys to an ideal contact when you're using anatomic mylar. Number 1, you've got to change the prep. Allow the composite to go around the tooth. Number 2, you got to pre-wedge. Just do it, man. My assistant does it. She puts in the pre-wedge. I'm taking a nap, right? I'm kidding. But no, my assistant does all my pre-wedging. It buys us a bunch of great stuff like we talked about. Number 1, then number 3 is you got to choose the correct matrix height. If you're using these anatomic matrices, it's not a sectional matrix. It's an anatomic tooth form. So don't be lazy like I used to be. Get the right matrix height. Use the matrix height indicator. Add 1 to 2 millimeters to the cavity prep because everything with this matrix is built into it for you. So if you use a matrix that's too tall or too short, you're not going to take advantage of all this beautiful anatomy. So we're going to be more disciplined with getting the right matrix height. Optimize the neighboring contact. A lot of these contacts are ragged or they're point contacts. Take a disc, optimize the neighboring contact. Progressive wedging. What the heck is that? Let's say I pre-wedge with a small. It's getting wiggly after a while. Use something bigger when you wedge. For the real thing, medium or large. That's progressive wedging. You want to place the separator like a rubber dam clamp. You got to wiggle it apically. Even if you're going to use, a weaker separator, if you wiggle it apically, you're going to pick up some more power according to what we've researched we've done and what Nate Lawson did, especially with the twin ring universal. Wiggle that baby apically, you'll pick up more power. Spot weld push pull. This replaces burnishing. Quadrant strategy, not talking about it today, but you can we'll have a webinar in the future about what do I do for a quadrant of MODs? How do I get great contacts in a quadrant? There is a great strategy we have for that. All right, now 3-point spot welding with deep decay. We're going to skip this video because I've only got 4 minutes to go, so I'm just going to show the case. A 3-point spot weld we do in the cavity is greater than 5 millimeters. We're going to have to put a gingival increment down before re-injection mold, and deep margin acquisition is recommended. What in the heck is that? Pack some cord to temporarily deepen the sulcus. Because people say, hey, David, what about deep decay? Man, I deal with that all the time. So I wanted to show one of these cases before we wrap up. So this dude comes in, he's got chronic food impaction, which almost always leads to outrageous decay. I told this guy, hey, I can do a crown, but realistically, there'll be almost no tooth left. Or we can injection over mold, rejuvenate this tooth with BioClear. $1,200, take it or leave it. You want a crown? Let's smoke some enamel, man. I'll do a crown. So the guy chose BioClear, even though, his insurance would cover a crown too. He wanted something more conservative. So $1,200 for this, because I'm going to work like a dog. All right. So first thing we're going to do, we're going to pack cord that releases the attachment. Our matrix is going to go 2 millimeters deeper. Here's the radius bevel. You can see that allows for flow. I've got 2 millimeters of calla lily horizontal enamel with my radius bevel. That's going to put the tooth into compression. So there's my matrix height indicator. Okay, we've been over this. We're number one, what color should I use? In this case, the roots are far apart. I'm going to use the blue. And what matrix am I going to use? What's my reference? Well, my reference is the marginal ridges of the neighboring tooth. So how deep is this prep, everybody? Oh, it's 6 millimeters. How tall should my matrix be? Well, it needs to be taller than 6, right? And if you pack cord and done deep margin acquisition, you're going to want probably an 8. So I'm going to use an 8 in here. It looks really good, but I got a sick feeling in my stomach when I looked at this matrix because the shoulders of the prep are gone because of the amalgam is so big, and the matrix has kind of a point contact. So this is why this new adjustable push-pull, or whatever you want to make in the garage to do your spot welding, is the ticket. So it's really not a very broad contact. So I put, there's a view of the whole assembly. We've got the twin ring on and wiggle it to place. And then we bring the adjustable push-pull in, and we're going to set it to about 6, pull this thing over, broaden the contact, do my spot welds, but then we also cure one on the gingival at the same time. So that's it's called a 3-point spot weld. And there's a final outcome, disassemble it. We're not going to make deep grooves. You can see that I've really expanded the contact beautifully because the matrix was not wide enough because the tooth was so small. So to be able to broaden the contact like that is really critical. All right. So we've been over the case. Let's do one more. Here's an endodontist from Texas that came in. Oh, I've only got 1 minute, and we're not going to show the endodontist from Texas. Okay, so let's go ahead, and I want to get to the last slide here. And there it is. So once again, it's a lot of material. And what I wanted to do is give you kind of a broad brushstroke of hitting on all the key things that we've done to change the way we think about posterior composites. Each one of these chapters could be dissected in great depth, and we have a lot of resources for you to do that. So it is 6:20. It's time for Q&A. All right, Aaron Reamer wants to know, with the thin composite extensions around the class 2, what is the risk of chipping on this thin composite? I get that a lot. That's an awesome question. So one of the things that happens is if you have this composite that's over enamel, it goes into compression. So even though it's super thin, if it's in what we call the compression zone in the occlusal of the tooth, we don't see chipping. Now, one of the reasons that we see chipping with normal composites is we haven't done a radius bevel that has a gradual transition from thick to thin. So we've got this thin area of composite that's not linked to the body of the composite. Number 2, we're not removing biofilm. And number 3, if you're extending the composite past the cusp area and you don't have a cusp to protect it, it breaks off. But ask yourself this, Aaron, you see a sealant placed on a tooth. They just throw them on there and they're still in there. Why? And they have infinity edges, basically because it's in compression. So we don't see chipping. And, at an opportunity, we can show you, a huge outcome study that they did where these, they don't fall out and they don't chip. I mean, anything can break. It's not 100%, but it's 99%. Okay. So the next question, Aaron's got a 2-for-1. Erythritol, you can use it. You'll be there all day. Aluminum trihydroxide is, I think, less expensive. And aluminum trihydroxide is definitely going to get you there faster. Let's see here. Melissa, why do you use the bonding as a surfactant? Doesn't it affect composite or bulk composite? Absolutely not. So Melissa, when we put the surfactant down, it allows the composite to flow to an infinity edge. Now, ask yourself this. When you're doing a porcelain veneer, you put adhesive on the enamel, you put adhesive on the porcelain veneer, you don't cure it, and you put basically flowable composite in between, and the adhesive is thinned out, and that's called co-curing. We cure at the same time. You don't have to use adhesive as a surfactant the second time around. You will not get infinity edge flow. You'll have little space on the x-ray. It won't flow. We tried it. And so all the outcome studies, all the studies validated at 3M, it's okay to use adhesive as a surfactant. Okay, isn't the occlusal bevel or infinity edge prone to microcracks? Absolutely not. It's in compression. Composite has the same compressive strength as Emax press. So in normal cavity preparations, none of this stuff worked. I get that. But with, I showed you a long-term outcome of these cases, and I show you 500 of these things. It's a different world. Okay. Alan Coopersmith. Oh, Alan, how you doing, man? Okay. What is he saying here? Instead of remembering numbers, did you ever consider placing the smallest dimension push-pull in the enterprise larger? I can't even understand you. You're smarter than me. Alan, I'm going to have to send you an email about the adjustable push-pull. I invented a couple years ago, and you and I are going to have a phone call because you're so much smarter than me that I don't even understand it. Okay. Is gingival bleeding an issue in placing the matrix? This is a great question. Here's the thing about mylar. It's different than metal. Metal is not as curved as the tooth. So metal always exits the sulcus and it slices the gingiva like a knife. The mylar is a little bit softer and gentler to soft tissue. And because it's so curved, when we drive it apically, we just don't see a lot of bleeding. Now, if I get bleeding, which I'll get once in a while, I'll take astringent and just bathe on the outside of the matrix while I'm acid etching, and that'll generally control it. But if you'll do the pre-wedge, you're going to have a lot less bleeding with matrix placement because the bleeding has been compressed over time. The papilla is smooshed out of the way. The sulcus is deeper. So I got to tell you, Ryan, we don't get a lot of bleeding. I think people talk to anybody who's done BioClear for like 3 years. They're going to go, oh yeah, everybody asks that. Bleeding's not really a problem. So, but I mean, for a newbie, it's like, oh my gosh, you got to be kidding. Anonymous says, hey, it was a good presentation. Hey, I appreciate that. Okay. Where do you sign up for the lecture that you mentioned? The Black Triangle lecture, I don't know which one they're talking about. So if you'll email me we can fill you in on all the different CE that we do at BioClear. And if that's what you're wondering about, or if it's this other webinar coming up, you can talk to my host. How does the need for vital pulp therapy material change this protocol? Hey, Stephen, great question. Okay. So so basically what Stephen is asking here is, David, if you could put teeth into compression with calla lilies and cuspal overlays and redesigning the preparation, I mean, just throwing composite in a hole is not going to make it different. This will not help you. There's some advanced conversations we'd love to have with you about cavity design to put teeth in compression. So what Stephen Jeffries is asking, hey, in a tooth that's got endodontic therapy, do I have to crown it or can I do BioClear? The answer is you have to provide cuspal protection and compression. And so we do not have to crown teeth after endo if we're going to be able to put these teeth into compression. And the outcome studies show you that the dentin in an endodontically treated tooth is different than the dentin in a tooth with a pulp, but it's not more brittle. So there's nothing really unusual about the dentin in an endodontically treated tooth. Problem is, usually those teeth are a little beat up and we drilled a hole in the middle of the tooth. And so we have to really protect that tooth. But what I do, Stephen Jeffries, after endodontics is I tell the patient, hey, I can do a crown or I can do BioClear. If we do BioClear, I can just do it at the end of your endo. Takes me 12 minutes. And then we can go ahead and do cuspal overlays and calla lily preparations. And we fill the endo axis with some boat fill flow. And then we design a retentive or compression-based cavity prep. So the answer, Stephen Jeffries, is we don't have to crown everything. And so, yes, you can treat endodontically treated tooth and endodontically treated teeth with careful design. And I'd love for you to come to the Learning Center or read some of the, articles about cavity preps, because they are, the preps are important. And at the Learning Center, it's a 4-day class. At the Learning Center, we spend an enormous amount of time going over all of the cavity preparations.